Welcome back, everybody. I must say this is a very uniquely enjoyable meeting. I haven't been to a mimosa conference in a long time, okay? So let's order up and have a good time. So we're getting into an extended realm, I guess, if you will, of the dry eye disease arena and the more severe part of it, neurotrophic keratitis. Kind of altered the title just a little bit. I'm going to try to simplify the approach to neurotrophic keratitis diagnosis and management. And I make an initial comment. The whole intent is to provide you confidence in what you're seeing, your diagnostic skills, and confidence in that you can provide effective management. Because right now, diagnostically, I've been in this realm a long time. I've been doing research in a neurotrophic disease for over 20 years. And I still remained amazed at how commonly this is misdiagnosed, okay? And even among very well-trained, high institutional trained cornea specialists, there's actually a study out that shows amongst cornea-trained MD folks that are working in the NK field, tested almost 50% of the time they misdiagnose it. Those are specialists, okay? What about the community doc? It's probably higher. So I'm going to try to teach you diagnostically how to accurately identify this disease in seconds at the slit lamp, and then we'll get into management. As management currently is problematic, NK does not respond to your traditional therapies, especially if you misdiagnose it, and there's much easier ways to deal with it, okay? So, disclosures, with a lot of companies doing a lot of clinical trials, and there they are. My introduction, neurotrophic keratitis, I like to call it the new queen of the ocular surface realm. And why do I say that? Just a few years ago, neurotrophic keratitis, stepchild, if you will, of the ocular surface realm. Nobody cared about it. Nobody gave it much thought. Nobody cared to treat it. And that has changed dramatically over the last few years. Now it's everywhere. Look at this symposium. There's just a couple of talks, hour long, and one of them is on neurotrophic keratitis. Wu University, in just the next couple of days, is going to have a series of 1-hour presentations on neurotrophic keratitis. And this is across the country. In your journals, I get emails on this condition extensively. It has completely changed. And why is that? I compare neurotrophic keratitis, what's happened to it in just the last few years, to the same dynamics as what happened with dry eye disease. 20 years ago, dry eye disease was nowhere. It was a stepchild of the ocular surface realm. If you were active in that realm, I mean, your colleagues looked at you like, get a life. Now it's a practice builder. What changed? For dry eye disease, the transformational time point was the introduction of Restasis. Finally, an agent that actually treated the disease. That opened the doors to legitimacy. And it's been running wild ever since. Same thing is happening with NK. And the transformational agent, 2018 FDA approved oxervate, Synigemin. Finally, we had a real pharmacologic therapeutic that went to the root cause. And that's what opened the doors to this disease. So, what is neurotrophic keratitis? It is a degenerative ocular surface disease secondary to damage related to sensory nerve of the ophthalmic division of the fifth or trigeminal cranial nerve. Damage anywhere along its course or further back will potentially produce neurotrophic keratitis. It does take a lot of damage, however, to do it. We'll get into some numbers here. Officially, NK is classified as a rare disease, fewer than 65,000 patients in the country afflicted. I think this number is way off, way low, okay? Mentioned I've been dealing in this realm for over 20 years, developed a network of referral, probably have over 500 cases in my library. It is rare that I get a case sent into me carrying the proper diagnoses. It's almost universally misdiagnosed, especially the milder, earlier cases, which we'll take a look at. Etiologies. In virtually all the etiologic profiles out there in the literature, infectious is number one. And when we talk about infectious, primarily the herpes family, whether it's simplex or zoster, something like 20% of all herpes zoster ophthalmicus cases eventually, maybe not at the beginning, but eventually will get NK. Ocular surface. Now, this is an interesting one. I mean, we're all aware on your refractive surgery, LASIK, you microkeratome the cornea, cut the nerves, and then you ablate them, you fry them with your excimer laser. Makes sense you would lose sensation and potentially enter in the neurotropic realm. The nerves usually will grow back over time. But what is missed in this listing, the number one source in my clinic for neurotrophic keratitis is my local retina surgeon. They don't know it, they don't buy it, but they do it, okay? How is that? Here's how. There's your trigeminal nerve, the eye, the cornea. It is innervated by the long posterior ciliary nerve, which enters the eye back by the optic nerve, runs anteriorly right under the RPE at the 3 and 9 o'clock positions, comes forward and innervates the cornea. Virtually any retinal procedure that's done out there can potentially damage that long posterior ciliary nerve. But here we go, pan-retinal photocoagulation. There's the RPE. The laser is targeting the RPE. That's what's being cooked. But where does that nerve run? Right underneath. So that heat is not limited to the RPE. It can go anteriorly to the retina and posteriorly to the choroid and cook the nerve. That is why I remember as a resident doing the pan-retinal photocoagulations on our diabetics and hitting this area, the patient would jump, okay? That is also why the recommendation on PRP is try to avoid the 3 and 9 o'clock positions, because that's where the nerve is. How about a scleral buckle? Buckles are intended to reduce traction on the retina by closing the distance between the two sides here, so you relieve traction. But that bends mechanically the sclera and can bend the nerve, that can damage it. Look at this case. Here's a scleral buckle that eroded right through the sclera and transected the nerve. So a scleral buckle can give you neurotrophic keratitis. How about a straight vitrectomy? Just a vitrectomy. It can do it too. How? Axenfels loops. I think you go familiar with that. You've seen it, but did you realize and appreciate what that represents is the anterior extension. This is a beautiful photomicrograph, histopathologic, long posterior ciliary nerve with an anterior extension manifested by Axenfels loop. And where do the retina surgeons, when they do a vitrectomy, make their port incisions? Right in this zone. Here we go, infusion line, port incision for your manual insertion of your instruments. You punch through there, you wipe out the nerve. So your retina surgeons, very high incidence. It's not high related to the number of cases. I had a chance to work with some retina surgeons, 2 of them, where I was the only one to get their cornea problem. So I got a fix on the frequency. An experienced retina surgeon, it was about 1% of his cases, and the inexperienced one was about 2%. So it's relatively low. But if they're doing 400 plus cases a year, you're going to generate some cases. Diabetes, systemic disease now. And actually, I mentioned the number one source of NK in my clinic is the retina surgeon, but it's multifactorial. And this is the classic combination in my clinic. A diabetic in my area, I'm in the Inland Empire of Southern California, Loma Linda area, big geographic area. Very Hispanic, heavy, lots of diabetes. These folks get proliferative vitreoretinopathy, and where do they go? To their local retina surgeon. And so I think the most common source, and this does not show up in the literature, multifactorial, if you see a listing of etiologies, there'll be a sprinkling of patients. Most of them, I think, are multifactorial. Each insult drops sensation a little bit, and if you get enough insult you'll get enough of an effect, and there's basically a threshold point numerically, like with Koshebin anesthesiometry, below which you enter into manifest visible disease. One other point here, I'm talking about multifactorial diabetics, commonly get another ocular problem, diabetes. If you treat that, I'm sorry, glaucoma. If you treat that glaucoma with a topical beta blocker, with that you can induce NK. A subset of the population, somewhere 15, 20%, turns out to be sensitive to the beta blockers in the form of anesthesia. So right there, my classic NK patient is a diabetic that has glaucoma, that's on a beta blocker, and has been to the retina specialist. Okay. Now we go to central nervous system. Post-neurosurgical procedures, those are usually fairly high up on the list of etiologies. And then finally, you get to your exotics, genetic, Riley-Day syndrome, golden R. Those are probably cases you're only going to pick up in your pediatric clinics. Okay, diagnostic considerations. Classically, any article you read on neurotrophic keratitis will upfront tell you how to go after to identify the disease, starting with a very extensive history. Well, that takes a lot of time to get. The concept there is to try to identify risk factors for NK. Then they talk about corneal sensitivity testing. Then they look at the patient's signs and symptoms, and classically, the neurotropic, you may see stain, but the patient does not complain of pain. Stain without pain. This is not how I approach my clinic patients. I go exactly the opposite. I have an extremely busy clinic. I have patients booked every 10 minutes. A new patient, I only get 20 minutes. I got to move, okay? Here's how I do it. In my clinic, it's a pure cornea referral clinic, and I understand the general clinics really can't operate this way, but I have a rule that is nobody touches the eye until I see them. The technician doesn't touch them, the resident doesn't touch them, and the fellow doesn't touch them. I don't want anything in that eye until I see them. I start with this. Check the patient at the slit lamp, white light look, and then some fluorescein. And I'm looking for, and what I'm going to show you here in just a moment, telltale repetitive evidence of NK. If I see something that looks suspicious, then I go to sensitivity testing. So this is very focused in terms of when I do this. I don't do it all the time, okay? But I can do it on the spot because no drops have been put in, no anesthetic. I don't have to bring them back for another visit to test them. Then if I get a positive here that I do have what looks like an NK, then I go back and get a focused history looking for the specific etiologies. So I'm doing it in the opposite way, but I think it's much faster, much more efficient, much more accurate. How do you test? First of all, most clinicians don't do sensitivity testing. Sorry to say that, but they just don't. They don't want to bother. It's too much of a hassle, takes too much time. Hopefully that's going to change over time as we get more and more conversant with NK. But if you're going to do it, and I encourage you to do it, most people will do like a cotton tip or maybe dental floss. If you're going to use a Q-tip, and that's a fine way to do it, you're going to get basically 3 levels of effect, either normal, hypoesthetic, or anesthetic. But if you use a Q-tip, make sure that you spin it up real tight. Okay, what you don't want is fibers coming off at 90 degrees. You may even have to check it under the slit lamp, make sure that's not there, because as you go in to brush the cornea, if those side fibers touch the lashes or the lids, you're going to get a blink reflex and you will think everything is normal. Now, I go quantitative, Koshebin, and I understand this is more research level. We're doing a lot of clinical trials in NK, but I've been doing Koshebin for about the 20 years. I love it. How I do it, Koshebin, by the way, is an instrument about the size of this laser pointer, has a nylon filament on a slider. Maximum extension is about 60 millimeters. The longer it's extended, the more flexible that nylon fiber is, and you touch the patient's cornea with a very flexible, loose fiber, they can feel it. It's a normal sensation. You shorten that fiber, it gets stiffer and stiffer. And if they're not feeling that stiffer and stiffer fiber, that's hypoesthesia. And it's numerical. The slider is numbered in millimeters, so you get a readout. Under slit lamp control, I can go back in and map the cornea. I can go back for serial sensations over time, going to the same area to see how things are changing with my treatment. And I mentioned you have to have profound loss of sensation to get manifest NK. Normal Cochet-Bonnet readings are considered to be 45 millimeters or higher. My average Cochet-Bonnet on my NK patients is 5. That's profound loss, but that's what it seems to take. A little bit of loss of sensation does not show up visibly on the slit lamp. You've got to get a lot of loss. That's why I think so many of these cases are multifactorial. Each insult dropping you further and further into hypoesthesia until you enter the disease realm. Okay. Now, here's where your mimosas come in. Kind of sit back. For me, this is the best part of the talk, the most fun. We've created a lot of new things in here that you're not going to find in the literature. Pattern recognition, rapid diagnosis. I'm going to show you now how to make the diagnosis in seconds at the slit lamp, and let's go. Start with the Mackey classification scheme. Eon Mackey in 1973 introduced this. It's really simple, just 3 stages, but the simplicity lends power. Stage 1, punctate keratitis. In my experience, roughly 90% of my NK cases fall into this category, and this is the category that's universally misdiagnosed as dry eye. Okay. Then as you drop into deeper hypoesthesia, you get stage 2, a persistent epithelial defect. And if you don't intercept this, you can go to a stage 3. You're now into stromal melt, ulceration, possible perforation, possible loss of the eye. So this is a serious disease. And these can move in and out of these 3 phases. Although in general, you're much more hypoesthetic in your stage 2 and 3 than your stage 1. Now, throughout all of the NK literature, the stage 1s are described as punctate keratitis, and that's it. No description of location of the punctate keratopathy. If there's a pattern to it, nobody describes that. I've actually identified, and I'm in the process of publishing a paper. There are 5 distinctive variants to stage 1: Golly spot, central band, blizzard or Milky Way, hurricane, or dendritiform. And what we're doing as we go through these, dropping deeper and deeper into hypoesthesia. Okay, then you enter stage 2 and stage 3. All of these variants, all stages and all variants originate from the same pathophysiologic process. To that pathophysiology, there are 2 key components: the corneal epithelium and the innervating subbasal nerve plexus. These 2 components are both physically and tropically, i.e. nutritionally, interdependent. The corneal epithelium produces neuropeptides and, critically, nerve growth factor, which is critical to the health of the subbasal nerve plexus and the nerves in general. The subbasal nerve plexus, in turn, produces neuromediators, which is critical to the health of the epithelium. So these 2 structures and components are intertwined, physically and nutritionally interdependent upon each other. Let's take a look at the epithelium. The epithelial surface is extremely dynamic. The whole thing turns over completely around every 6 days. The source of all those new cells are the limbal stem cells located 360 degrees around the cornea. As they produce the new epithelial cells, those cells stream radially and centripetally. Intuitively, you would think they would meet at the center of the cornea, the corneal apex, but they don't do that. They meet instead at what we call the corneal vertex, which is located roughly 2 millimeters below the apex. And as they approach the vertex, they start to spin. They rotate. And 90% of the time, they rotate clockwise. Why is that? There are a couple of theories to explain that rotation, but I think the most compelling one was put forward by Dr. Dua, who identified that there is an electrical charge in the eye, front to back, a differential. That differential in charge creates a magnetic field. Don Gass, and I don't know if you folks, this is a pretty young crowd, just an iconic retina gentleman out of Bascom Palmer, identified ferromagnetic cellular deposits in the central cornea of all cadaver patients. So now you've got magnetic material sitting in a magnetic field. You can see where that could create a spin. Okay. Now let's turn to the subbasal nerve plexus. This, I think, is a gorgeous photomicrograph of a real human cornea. This is not a painting, a drawing. This is the real thing, generated by hundreds of isolated pixel images taken by special photography techniques, showing you the subbasal nerve plexus. And there again, you can see the nerves streaming radially and centripetally, and then coming together at the corneal vertex, okay? When they get there, again, they form that swirl, or even in some cases, like a seam, okay? Now, what's happening here is the nerves, I think, essentially are being dragged. The whole thing, the nerves and the epithelium move together. They move in tandem to that vertex zone. I think the nerves are being dragged by the dynamic movement of the epithelium. Those two components, the epithelium and the subbasal nerve plexus, establish the corneal vertex zone. And if you're going to remember one image out of my entire talk, this is the one I want you to remember. That's the corneal vertex zone, and it's what I call the neurotrophic hot zone. Everything comes out of here. Everything. Okay? If you remember that, this is where you're looking for NK. All right? So let's go into pattern recognition and see how this works. Here is a garden variety dry eye. Punctate keratopathy, inferior. It's a left eye. Here's the punctum. The punctal, the nasal lacrimal duct system is dynamic. It's not static. When you blink, you create a vacuum and it'll just suck the tears away. That's why you see this predominantly by the punctum. That's a garden variety dry eye. Has nothing to do with the corneal vertex. Here is a stage 1 NK. Classic. And this is how they come at you over and over and over again. Infracentral, horizontally oval elongated punctate keratopathy doesn't go to the limbus. Some publications will tell you that it does. Usually does not. Classic. But to see it, you've got to use fluorescein, and a lot of clinicians don't. If you don't use fluorescein, you're going to miss NK. Let me show you. Here's a patient sent in to me. Patient had diabetes, underwent pan-retinal photocoagulation for proliferative diabetic retinopathy. You see, we're getting into our multifactorial here. Then had cataract surgery, but complained of poor vision, 20/40. Back to the retina specialist who run through all their OCTs and everything and determined the macula is normal. So they can't explain the trouble with the vision. They send the patient to the neuro-ophthalmologist who gets CT scans, visual fields. They can't come up with anything. They send it to me. I see the patient. Nobody touches them. I look at them. First thing I do is put it in the fluorescein. Bingo. There's the answer. Took me 2 seconds. Okay. Stage 1, infracentral with effect into the visual axis, knocking the vision down to 20/40. Easy, quick. This patient spent weeks with multiple specialists trying to figure out their visual complaints. Okay. Now, I'm going to get into breaking down stage 1 because there are these 5 variants. And with this, you're going to learn the different variants. Okay. You won't find this information anywhere in the literature. It doesn't exist. We are creating it. It's going to be in my upcoming publication. Galley spots, central band, blizzard Milky Way, hurricane, and dendriform. Let's start with galley spot. How many of you have heard the term galley spot before? Okay. You've probably seen it, but you didn't know what it is called. Let's take a look. The term galley spot was coined by J. Galley in 1891 to describe what he said were Delin-like lesions in rabbits, okay? That term languished for almost a whole century until 1973, when Ian Mackey of the Mackey classification scheme connected the term to neurotrophic keratitis, declaring it, he considered it to be the earliest sign of NK. What we have identified through Cochet-Binet testing, it demonstrates the least amount of sensory loss of all the different variants of NK. Consequently, it is the most treatment responsive of all the NK variants. It is rare. You don't see it much. The lesions are very unique and of a fleeting or evanescent nature. I've seen these things come and go in just 24 hours without any change in treatment. The lesions themselves are very discrete, vertically elongated, in fact, columnar facets of PEE. They're usually located within and or above the corneal vertex zone. In more extended forms, they can assume a vortex or versalata configuration. And there you go. Anybody seen anything like this? A couple of you? That's galley spots, okay? Vertically elongated facets of PEE, not that little field of punctate keratopathy. Very unique. When I first saw this patient, at first blush, I went, oh, here's a galley spot, dry eye. But then I did a second take on it. It's like, wait a minute. Where are all these lesions located? Draw a little circle around this, oval. They're in the corneal vertex zone. Could this be NK? So nobody's touched this eye except for fluorescein. Get my Cochet-Binet, and sure enough, this is the left eye. The right eye is 60 millimeters, maximum you can get on Cochet-Binet. This eye is only 13, okay? Why is there such a difference? This patient had seen their local retina surgeon for repair of a macular hole within, they got pars plana vitrectomy and endo laser, okay? Easy explanation. There's my sequence. Spot what looks suspicious for NK, verify with sensation testing, then go back to the history and nail it down. Here's a much more advanced galley spot. We're getting into vortexing or verticillata configuration here. Pick these up. Staining-wise, you have to leave the fluorescein on for a little bit. The ideal staining time to observe these kind of lesions is fluorescein on for somewhere between 2 to 4 minutes. This may not show up initially within the first few seconds of the fluorescein, okay? And a little fun, galley spots. The word spot to me means circular. These things are not circular. I think maybe a little misnomer on the name. I'm kind of a weather geek. If I didn't have to spend so much time in the clinic, I'd like to go storm chasing. There is, anybody here sprites in association with thunderstorms, red columnar sprites? This is an electromagnetic phenomena associated with cloud to ground lightning strikes high above active thunderstorms, 30 to 70 miles up, okay? But they're columnar in shape, or they can take that shape, to me, and they're fleeting, very similar to me to the galley spot characteristics. Maybe we should rename this sprite keratopathy. They're not spots. Okay, let's move on. Stage 1 central band. Again, you won't see that name in there, but I think it's very descriptively accurate. And there, I've already shown you this picture, but that's a central band. Here's another one. I've shown you this one. Again, central band. Look at it over and over again. It's the same thing, same location, same configuration. It's so repetitive. And here's a post-LASIK, same thing, okay? And again, doesn't go to the limbus, stays in the central 1/2 to 2/3 of that infracentral cornea. Blizzard, Milky Way. And by the way, that central band, that's the most common presentation you're going to see. That overwhelms all the other presentations in terms of frequency. Blizzard and Milky Way. Deeper into hypoesthesia, we now are getting extension of the punctate keratopathy across the cornea, maybe involving almost the entire cornea. But if you look carefully, where is the highest concentration of punctate keratopathy? Same place, corneal vortex zone. Oh, by the way, this patient, etiology, acoustic neuroma surgery back in 1998, who complained immediately after the surgery of problems with her left eye. In the span of 20-odd years, she saw more eye docs than she could remember. Every one of them told her the same thing. You've got dry eye, but nobody could fix her. She comes into my clinic, I go through my routine, put in the fluorescein, look at her, bang, 2 seconds. This looks like NK, I confirm with Gaucher-Bonnet, okay? She spent 20 years chasing this. Now we're getting deeper into hypoesthesia, hurricane and vortex. Just as a reminder how that movement is with the corneal epithelium, normal dynamic movement, forming like a hurricane type configuration down here in the vertex zone. The corneal, you don't see this normally because corneal epithelium is transparent, but anything that will visualize the epithelium will demonstrate this pattern. What's a classic for that? A disease state? Fabry's disease. There it is, streaming radially, the epithelium, sphingolipidosis is deposited into the epithelium, allowing you to see it, comes down to the corneal vertex and spins clockwise. The term hurricane keratopathy was coined back in the 1980s by a gentleman who was doing a lot of corneal transplants and saw this a lot in his patients, since confirmed by multiple people who commonly can get this right after transplant surgery. The thinking then was it was because of all the steroids we're pouring in, okay? Nobody connected this to NK. We finally did in 2004, took this to ARVO, looked at a series of almost 80 patients that had corneal vortexing or hurricane keratopathy, and about 80% of them were neurotropic. Let's mag up. I think you can start to appreciate that radial effect and the vertex. What we finally assumed and concluded was that if you see this staining pattern, and I'm not talking about Fabry's disease, which won't stain, or the drug deposit verticillatus, which again won't stain, a staining hurricane pattern to me pathognomically is neurotrophic keratitis. And here's just a beauty. The Ratten filter was mentioned several times by Corey here earlier today. I've really taken to it too. It really brings out detail. Look, this is just a florid hurricane. I mean, I start to salivate when I see these in the clinic. My technician, when she sees me looking at this, she brings my lobster bib because I don't want to drip all over me, okay? I love these. This is, that's just on a scale of 4 stars, that's a 5-star, okay? Just gorgeous. And here we are, the final one in the stage 1 territory, dendriform, okay? There is a variation on this vortexing pattern which can form wings that look kind of like dendrites, okay? What's the common condition that will show you that? Amiodarone keratopathy. Every patient on amiodarone will demonstrate this kind of pattern to some degree. Usually it's very mild, doesn't affect vision. This was a real 4-pluser, but it really shows you're getting into the dendritiform look. Now, it's important to differentiate that from the real thing. This is real active herpes simplex. How do you tell the difference? Active herpes has several characteristics to it. Dichotomous branching, end bulbs, random location anywhere on the cornea, random orientation anywhere, okay? and discrete. It's not sitting in a big field of a punctate keratopathy. Here is neurotrophic dendriform stage 1, a real mild one, but we're starting to get these radiations which can look like a partially healed dendrite. But notice the orientation, horizontally oval, sitting in a field of punctate keratopathy. No end bulbs, no dichotomous branching. Here's another one. This could be a little trickier. That's really starting to look dendritiform, but orientation, horizontal, in the corneal vertex, surrounded by a field of punctate keratopathy. There's the rat and filter, the same one. This is a hot one. This really looks suspicious, but this is just a straight up stage 1. Actually, if you really look, kind of horizontally oriented in the vertex zone in a field of punctate keratopathy. Rat and filter, the same one, really wild looking. Here's a real tricky one. This one I could see could really fool a clinician. Look at that. Ooh, do we have dichotomous branching here? Are these end bulbs? But look at the orientation, horizontally oval, in the vertex zone, in a field of punctate keratopathy. Once you've got all those items down, it's easy. And why is this important? Because your average clinician will think this is active herpes, will treat it with topical antivirals like Viroptic, trifluridine, which are ultimately toxic. They treat it for weeks and weeks. It doesn't get better. In fact, because of the toxicity, it gets worse. Okay? Easy to identify. Now, the last two I just showed you, hurricane and dendriform, are significant sensory loss within the stage 1 realm, just an incremental step away from the next stage, stage 2, and this is a classic. Stage 2, again, repetitive, and I hate to repeat it again, horizontally oval, elongated, located in the vertex. Now we've lost the epithelium, rolled edges. That's the epithelium trying to heal, but it can't. But also look at something else. See these radiating lines coming out? This, in its earlier life, maybe just days ago, was a dendriform lesion. Now it's hollowed out in the core center, but you still see traces of that dendriform shape. Here's another one. Stage 2 in the vertex zone. This was probably just a little bit ago, a hurricane or vortexing. You can see the radiating lines coming out. So when you reach dendriform and hurricane, you're just an incremental step away from stage 2. And these can move in and out stage 2, dendriform, hurricane, stage 1, back and forth between those two stages. Finally, stage 3. Here we're losing stroma, we're ulcerating, as you can see here by this thin beam slit lamp. Also, this is really a nice one. The margins of this ulceration showed dendriform color, and then the whole thing is sitting in a field of punctate keratopathy. It's a stage 3, sitting within almost a stage 2, sitting within a stage 1. It's like a bullseye. But so repetitive in the pattern, over and over again. And finally, a straight up bad stage 3. Notice something though, the ulcer is a little bit out of position. It really should be up here. Why is that? This gentleman had a ptosis, changed the interpalpebral fissure window, if you will, moved everything down. And finally, the ultimate stage 3, we're down to desmetocele here, and a big one. This patient is a cough, a sneeze, a bump away from blowing that out and losing the eye. And he doesn't feel it. Okay? This guy didn't know anything was wrong. Okay. Now, if you have the disease for a long period of time, chronically, you can get what we call central isolated calcific NK, calcium deposit within the disease zone. Okay. It can assume any of the NK variant patterns. Here is true band keratopathy. You don't want to confuse that term with our term. True band keratopathy starts at the equatorial limbus. The calcium progresses centrally until it finally forms a band across the whole cornea. That's not how the NK calcific works. It is. This is a stage 1 with calcific deposit. So it's isolated in the center. Here's another one, like a cloud-like look to it, but it's not emanating from the limbus. This was a stage 1 calcific. This was a vortex calcific. I called it a frozen vortex, okay? Again, this calcific deposit over time can assume the shape of the underlying NK, any one of them. That same case with fluorescein, you can see we're in a stage 1 here with punctate keratopathy. Here's a stage 2, stage 3 with calcium deposited within the core of the lesion. Again, central isolated, not a true band K. Here's another big one. And why is it important to identify this as an NK complication, if you will? Because the clinician may want to remove the calcium, do an EDTA chelation, scrape and peel. What are you going to be left with? A big epi defect there, which won't heal. And you wonder why. All of a sudden, you've created a big problem. If you know what you're getting into, you can be prepared. Okay. Treatment. Here are some of the standard treatments. Artificial tears, which really don't do much. Steroids, which you use. I mentioned at the other presentation, straight up NK is non-inflammatory. It's quiet. If you have inflammation, there's something else going on, like an immune stromal keratitis or herpes shingles or simplex, and steroids are appropriate there. Autologous serum. Some people really like it. I get lots of cases sent in to me that have been on this and it doesn't work. Antibiotics you do use if you're stage 2 or 3 so you don't get infected, because if you get an infected case of stage 2, stage 3, it is a nightmare. It won't heal because of the NK. In-office procedures, bandage lenses, of some help. Before the advent of oxyrvate, this was my go-to, but you had to be aggressive, i.e. cautery. Plugs frequently were inadequate, and you had to get aggressive with punctal cautery. Eyelid closure, non-surgical, that's Botox. It's temporary. Amniotic membrane, I don't use that. I get lots of these sent in to me with that, where it's not working. It's temporary. If you get healing here, you're still sitting on a powder keg because you haven't addressed the underlying sensory loss, and any little insult will set off the whole process again. Tissue adhesives, that's glue. You're only using that if you perfed or about to perf. That doesn't do anything for the underlying neurotropic. Tarsorrhaphy works. Patients hate it. Looks terrible. Same with the conj flap. Corneal transplant, you're just buying time on an eye. The NK will come right back on your transplant. And direct nerve this is nerve transfer surgical. Some people are playing with it. Very complicated. You got to have an oculoplastic specialist to do that. Variable results. So let's move on now. We're going to try and simplify the treatment because a lot of that stuff doesn't work. The molecular pathophysiology of NK, nerve growth factor. Believed to support corneal integrity through 3 mechanisms. Grows nerves, enhances reflex tear secretion, and promotes epithelial cell proliferation. This is where oxyrvate comes in. What is oxyrvate? Recombinant human nerve growth factor. It's actually the very first topical biologic we've ever had in the eye realm, approved by the FDA in 2018 for all 3 stages of NK, accorded orphan drug status and deemed by the FDA, and I've never seen this before, a quote, FDA quoted breakthrough therapy. They were so impressed with the clinical trial. Synegemin, that is the active ingredient in oxyrvate. It is structurally identical to endogenous nerve growth factor found in the human body. Let's take a look at the clinical trials. 2 studies utilized by the FDA to approve oxyrvate. The European study called Reparo and the US study, which we were a part of at Loma Linda, 11 sites. We were one of them. I was the primary investigator. Reparo, 156 patients. We had 48. To get into the study, everybody had to have a stage 2 or stage 3, no stage 1s. People put into either the vehicle or the drug and treated for 8 weeks, which is the current treatment regimen for oxyrvate. Followed up 1 year in the European study, a half year for us. Primary endpoint, what proportion of these stage 2, stage 3 were totally healed at the end of 8 weeks. And here are the results. The European study, about 2/3 totally healed at week 8. US study, about, but 75 or 3/4 and 2/3 for the US study. How long did it last? Look at the European study, followed for a year. 80% of them remain healed at the end of 1 year. What do you do if it recurs? Hit them again with oxybate. What do you do when you treat them with oxybate and they don't respond? Hit them again. I go up to 4 rounds on oxybate. And very quickly, I'm going to do some case studies because we're coming up on our endpoint in time. Golly spot. I showed you this one. Put them on oxybate, everything cleared in 3 days. Finished the 8 weeks, never came back. Okay. Number 2, remember this guy? Okay. Had shingles, bad case. He had pseudodendrites, endotheliitis. I knew he was going to have trouble with his cornea. We got him through the acute phase. And then he had a staining pattern that kind of looked like stage 1, but I did Cochet-Binet on him and he was normal, 45. So I just treated him as a dry with a plug. Back in 2 months, the plug had fallen out, put the plug back in, bring him back in 2 months. I walk in the room. Hey, Norman, how you doing? I'm doing fine. No problems? No. Pull up the slit lamp. Boom. He didn't even know he was about to lose his eye. Doesn't feel it. It's not affecting his vision. What did we do? Treated him with a bandaged contact lens, ordered up the oxybate, and after 2 weeks of treatment with a new plug, he had not responded at all. So we get the oxybate over a bandaged lens, and he healed in roughly 5 days. If you look at the Reparo study, the European study, 156 patients, who identified the time point where they finally healed, this guy comes in number 1, the fastest of all. Why is that? The company tells you not to use a contact lens. They're afraid it'll interfere with distribution. I think what it does is acts as a drug depot and a time release of the agent, enhancing the drug effect. Okay. And in the interest of time, we're going to skip this one. This was an active dentist, treated with all the things we've talked about unsuccessfully. Took him to emergency surgery, but I knew once we did the transplant, all of this was going to fall apart. We're going to go down the same rat hole. Day 1, total 100% epi defect, put a bandaged lens on him, come back a week later, and he's totally healed. Oh, I'm excited. I wasn't expecting that, but I know he's going to break down again. We get the oxybate. We treat the oxybate over the bandaged lens. Here he is at month 2. When he finishes his oxybate, never got even any punctate keratopathy. Vision uncorrected, month 2 on a transplant, 20/40. And it remains that way all the way through the follow-up, never broke down again. What it brings up is the concept of using preoperative oxybate in any known neurotropic case before or in your perioperative period to prevent recurrence of the disease. The final slide here, oxybate generation 1 NK treatment, whole new generation coming. We've got 4 clinical trials at Loma Linda alone, NK agents, very exciting hepatocyte growth factor for not only NK, but scar reversal of corneas. Kala Pharmaceuticals, mesenchymal stem cell secretome for all persistent epithelial defects. NK only accounts for about 1/3 of those. Then Regen and Nexagon is on the way. We're waiting to get that. We're running these 3 right now. And the final item, limbal stem cell deficiency. A disease even worse than NK, but coexistent at times with it. Why do I say it's even worse? It's blinding and it's painful. NK doesn't have pain. Up to this point, I think I mentioned this earlier, there has been no pharmacologic treatment for NK. We have successfully treated these cases with a combination of Acthar I talked about earlier and hepatocyte growth factor. And based on that success, we're starting the clinical trial on it in just a few weeks, I hope.